Hello, everyone. Welcome to Rock the Mic Postdoc Fast Pitch. I'm your host, Yashni Govender. I'm a postdoc at Brigham, and I'm also the president of the Postdoc Leadership Council. So today we have a lineup of 4 postdocs who will be presenting their research to you, and they will each have 4 minutes to present this research. And then you, the audience, will have the chance to be the judge. You will first provide feedback on each of the pitchers' presentations, and at the end, you will also rank the pitches from 1 to 4, and number 1 will be the winner. So the polling system that we will are using, you'll be provided a link, and after each pitch, you can go in and provide your feedback to each of the presenters based on their clarity, the significance of the research, their enthusiasm, and their composure. You can rank them from 1 to 5, 1 being low and 5 being high, and you'll have 1 minute after each pitch to provide this feedback. And then at the end of the presentations, after the 4th speaker, you will then choose the winner. You will rank them, 1 being the winner, and 4 being the 4th option. So you'll be provided the same link to rank your the speakers, and the winner will win a cash prize of $1,000. So let's get this show started. So first up, we have Dr. Abha Aggarwal. She's a research fellow in the Department of Surgery and Surgical Oncology. Her talk is going to be on the glycolytic inhibition with 3-bromopyruvate and ketogenic diet increases survival in a mouse model of anaplastic thyroid cancer. On to you, Abha.
Hello, everyone. Just took a little bit of time to share my slideshow. Thank you, Yash, for the great introduction. I'm very excited today to present our research findings on anaplastic thyroid cancer. Anaplastic thyroid cancer, or ATC, is a fatal malignancy. It has a 5-year survival rate of only 4%, and currently there are no effective treatments for this devastating malignancy. Cancer cells use glucose as their energy source to grow rapidly, and this phenomena is called the Warburg effect. We can see this effect when we do PET scans for cancer diagnosis, where the cells are taking up the glucose that is labeled and they light up. So we hypothesized that glycolytic inhibition and dietary carbohydrate restriction would then lead to reduced tumor cell growth. For our experimental design, we used a 3-pronged approach. First, we used low glucose, or we used a ketogenic diet, which has a low carb and high fat content. And this diet mimics a low glucose environment. Second, we used 3-bromopyruvate, or 3BP. This inhibits hexokinase 2, which is an enzyme that's used for glycolysis. Third, we used a combination of low glucose or ketogenic diet along with 3BP treatment. We performed cellular assays using an ATC line called 8505C. We exposed this cell line to either high glucose, low glucose, high glucose with 3BP supplemental, and low glucose supplemented with 3BP. High glucose was used as a control. Our proliferation assays showed that when we add 3BP to high or low glucose, we see a significantly lower proliferation in 96 hours compared to the high glucose as well as low glucose conditions. For our invasion assays, we found that low glucose significantly reduces in cellular invasion compared to the high glucose control. And this effect is further amplified with high glucose and 3BP. And we saw the maximal reduction using low glucose plus 3BP when compared to the control. Our migration assays showed that all 3 of our treatment groups worked equally well when compared to the high glucose control. So after seeing such successful results in our lab experiments, we wanted to take this one notch up and do mouse modeling, for which we took 33 mice that were immune compromised, nude mice, and we injected about 500,000 of 8505C cells into the mouse thyroid gland, as shown in this picture. Then we divided these mice into 4 groups. And the first group we used as a control, which was the standard diet group or the SD group. The second group was the ketogenic diet group or the KD group. The third group was the SD diet plus 3BP group. And the fourth group was KD diet plus 3BP group. The 3BP treatments we did for 5 weeks daily, and we did this via IP injections. We started all our intervention 1 week post-surgery. 4 weeks into our treatment with 3BP, we did PET scan imaging, and we saw that the standard diet mice show large tumors, whereas the ketogenic diet with the 3BP, we did not see any obvious tumor growth in these mice. Our survival analysis at 58 days or the 9th week, we saw that the ketogenic diet along with 3BP group, all of our mice survived, and this was a significant increase in survival compared to the standard diet or the ketogenic diet. Our 3BP mice with the standard diet showed some effect, but it wasn't significant. In conclusion, our study showed that ketogenic diet with a glycolytic inhibitor 3BP significantly decreased tumor volume and increased survival in an ATC mouse model. Okay. And low glucose plus the 3BP significantly reduced cell proliferation, invasion, and migration in our ATC line. Its clinical implications are that the combination of glucose restriction along with glycolytic inhibition may lead to an effective adjuvant therapy for ATC patient management. With that, I'd like to thank you all for listening.
Thank you, Abha, for that insightful talk on your research. So, audience, okay, can you just stop sharing? Yeah. No worries. Audience, you'll have a chance now to provide some feedback to Abha, and the link is in the chat. It's been posted in the chat, and it's also, you can try and get it from here if you don't see it in the chat. You'll have 1 minute to provide your feedback based on those 4 categories, and this is going to help Abha and all the other presenters for future presentations. Okay, and then while you guys are finishing up your feedback, I think we can go and go ahead and introduce the next speaker. The next speaker is Dr. Andreas Ardisson Korat. He's a research fellow in the Department of Medicine at the Channing Division of Network Medicine. His talk is going to be on fruit and vegetable consumption and non-Hodgkin lymphoma risk. Okay, Andreas, off to you.
Thank you. Can you see my slides now?
Yep, looks good.
Thank you for the introduction. So what if we had tangible prevention strategies for non-Hodgkin lymphoma, which is the 6th most common cancer in the United States and has more than 40 different subtypes? About 98,000 people in the United States are likely to be affected by this cancer this year alone. This disease causes death within 5 years for 70% of those patients who get the subtypes that progress more quickly. And the treatment is very expensive. So what if we could prevent a fraction, if not all, of those people from experiencing the devastating personal, health, and financial hardship that can accompany this diagnosis? Would you believe me if I told you that one of the potential prevention tools could be within our reach in the foods that we eat? As it so happens, and as you may already know, fruits and vegetables are sources of nutrients, vitamins, and minerals that could be useful in the prevention of lymphoma. That's why I've just finished a study investigating the association with lymphoma risk. In this study, we used data from 2 long-standing cohorts of health professionals, about 77,000 women in a nurse's health study and about 48,000 men in the health professionals follow-up study. It is remarkable that these participants have answered questionnaires every 2 years, providing information on their weight, exercise and smoking habits, medical history and medication use for the last 3 to 4 decades. And every 4 years, they answered a detailed dietary questionnaire from which we derived their fruit and vegetable intake. Also, whenever they reported a lymphoma diagnosis, they gave us permission to look into their medical records to confirm that they indeed had non-Hodgkin lymphoma and to identify the subtype. So overall, we identified 1,614 non-Hodgkin lymphoma diagnoses over 26 years of following up this dedicated group of participants. Based on our calculations, we did not see associations of consumption of any kinds of fruits and vegetables with risks of all subtypes of lymphoma combined. However, we observed interesting findings for diffuse large B-cell lymphoma. This is the most common subtype and is one of the most lethal ones. We found that eating 2 more servings per day of total fruits and vegetables was associated with a 19% decreased risk of diffuse large B-cell lymphoma, which is quite remarkable. 2 more servings per day of vegetables alone was associated with 28% decreased risk. 2 more servings per day of vitamins, fruits and vegetables high in vitamin C was associated with a 34% decreased risk of diffuse large B-cell lymphoma. And what's more, this group of fruits and vegetables was also associated with a 27% decreased risk of chronic lymphocytic leukemia, which is a different subtype that progresses more slowly. 2 more servings per day of beta-carotene-rich fruits and vegetables, such as carrots and sweet potatoes, was associated with a 41% decreased risk of diffuse large B-cell lymphoma. And 2 more servings per day of lycopene-rich fruits and vegetables was associated with a 69% lower risk of diffuse large B-cell lymphoma. These results were not affected when we controlled for other risk factors such as age, sex, obesity, exercise levels, history, or autoimmune disease. In conclusion, our findings suggest that increase in intake of several types of fruits and vegetables may decrease the risk of some types of lymphoma. Existing public health efforts through, for instance, the US dietary guidelines promoting fruit and vegetable intake may contribute to non-Hodgkin lymphoma prevention. And finally, our findings may help inform new dietary prevention recommendations through organizations like the World Cancer Research Fund, which currently does not have guidelines for lymphoma. And with that, I would like to thank you very much.
Thank you, Andreas, for that talk and highlighting the importance of eating or increasing the intake of fruits and vegetables. So you guys can use the same link. It should be updated now to provide some feedback to Andreas. So that link again is in the chat, and I'm just gonna bring it up again. So go ahead and provide feedback to Andreas. And I'll just give you a few more seconds, and then I'll go ahead to introduce our next speaker. Okay. So our next speaker is Dr. Ania Syrowatka. She is a research fellow in the Department of Medicine, General Internal Medicine and Primary Care. Her talk is going to be on development of electronic clinical quality measurement quality measure for respiratory depression after total hip and total knee surgery. On to you, Ania.
Thank you. Thank you for the introduction. Our team has been funded by the Centers for Medicare and Medicaid Services to develop a set of electronic clinical quality measures to report on the safety of care after total hip and total knee surgery. One of these measures will report on how many patients experience respiratory depression after their surgery. Respiratory depression is when your breathing becomes slower than normal and your body may not get all of the oxygen that it needs. This can cause serious harm. It can cause your heart to stop beating, cause injury to your brain, and it can even lead to death. Our team has developed an accurate way to count how many patients experience respiratory depression after their total hip or total knee surgery to help improve the quality of care. We started by taking a look at measures that are already reported by reputable sources such as Hospital Compare. We then took a look at research that has been done to understand how we can measure respiratory depression. We engaged key stakeholders to ensure that we develop a meaningful measure. So we talked with total hip and total knee patients, their caregivers, orthopedic providers, researchers, and payers to get their guidance on what we should measure and how we should measure it. We then tested the clinical quality measure at the Mass General Brigham, which includes Brigham and Women's Hospital. What makes our research innovative is that it relies on electronic health record information. Most measures rely on information documented in hospital billing. By using the electronic health record, we have access to a whole lot more information, and this includes your vital signs. So for example, the level of oxygen in your blood. So for the purposes of our measure, this means that we can more accurately report on the occurrence of respiratory depression after your total hip or total knee surgery. This measure will be reported at the orthopedic group level, since there's an entire team of people that work together to ensure that you have safe and high quality care after your surgery. Here we present our preliminary results. So overall, at the Mass General Brigham, if you use all the different groups together, we see that approximately 3 out of 100 patients experienced respiratory depression after their total hip or total knee surgery. And the important thing to note here is that lower numbers do indicate safer care. So when we start breaking it down by orthopedic group, you can see, for example, that one group did much better. So group E has a much lower number. On the other hand, other groups did not do as well. So if you take a look at group D, you can see that more than 6 out of 100 patients experienced respiratory depression after their surgery. And this is 2 times higher than the overall Mass General Brigham number of 3 out of 100 patients. So this shows us that there are really important differences between orthopedic practices. So our team is still in the process of refining this measure. Our next step will be to adjust for patient factors such as age and other health problems to make sure that we create a measure that gives us fair comparisons between groups. So as a patient, this information can help you choose where to get your total hip or total knee surgery. And as a provider, this information can help you understand how you compare to other orthopedic practices and whether there are opportunities for you to improve the quality of care that you provide to your patients. Our goal is to submit this measure for National Quality Forum approval in 2021. If our measure is approved, it could be reported by the CMS annually across the United States to help improve the quality of post-operative care. Thank you very much.
Thank you, Ania, for highlighting your research at the Brigham. So again, you guys can go ahead and click on that link to provide some feedback to Ania. And just a reminder to stay till the end of the talks, because that's when you will be ranking the winner. Okay. On to the next and final talk. We have Dr. Jessica Williams. She's a research fellow at the Department of Surgery and Cardiac Surgery. Her talk is going to be on what matters more, size or shape, effect of artery shape on patient risk. On to you, Jessica.
Okay. So the aorta is the largest vessel in the human body, and any disruption to normal blood flow can cause a plethora of adverse clinical events. One of these is aortic dissection, which is a tear in the aorta wall, and it means that blood flow can then flow into the lining of the aorta. And aortic dissection is extremely lethal, with a 90% mortality rate at 1 year if it's left untreated. But even if it's treated, there's still a 22% in-hospital mortality rate. And this is because aortic dissections are very complicated to treat. So really the best way for us to lower the mortality rate is to be able to administer appropriate preventative care, which means we need to be able to accurately predict which aortas are likely to dissect. The current clinical indicator of whether an aorta is likely to dissect is its maximum aortic diameter. For a normal adult, the range is between 2.2 and 4.2 centimeters, and a patient is considered at risk if its maximum diameter is above 5.5 centimeters. However, it's been shown time and time again in existing literature that this is actually a poor indicator of dissection. And this is shown in the plot on the right here, where we see on the horizontal axis the maximum aortic diameter, and on the vertical axis we see the number of aortas in each of these size categories that dissects. And actually, as indicated by the shaded bars, 59% of this data set were less than 5.5 centimeters, and they still dissected. So that indicates that perhaps this single anatomical measurement doesn't provide an accurate risk estimation. And perhaps what if it's more than just a single measure, but actually something about the three-dimensional structure of the aorta that dictates its dissection risk. So this is what we're studying. And in order to do this, we need to be able to get patient-specific geometries. And we do this by looking at CT scans of their thoracic region. We inject a contrast into the aorta so that it shows up more brightly than the surrounding anatomy. And this allows us to use image segmentation techniques to extract a three-dimensional geometry. And if we then do this for a number of different patients, and where we know their clinical outcomes, in actuality, we're looking at a large data set, but here I'm just showing 10 for illustrative purposes, we can group these into aortas that don't dissect and aortas that do dissect. And just for interest, I've indicated their maximum aortic diameter here. And you can see that these are really not different between these two groups, which further validates the need for an improved risk metric beyond simply maximum aortic diameter. So what we're doing is we're applying a mathematical technique called statistical shape analysis to determine the amount of variation amongst a cohort of individual shapes. And importantly, what statistical shape analysis can do is that it can allow us to find a shape mode that's correlated with an outcome of interest, which here is dissection. So here's a video of an aorta shape deforming along this shape mode that's correlated with dissection. And a way to visualize this is to think of having an average shape and then deforming that shape in both extremes away from the mean to get shapes that are correlated either with dissection or not dissection. And these shapes are subtly different, but the dissection shape has a slightly larger radius of curvature and the ascending and descending portions are more equal than compared with the no dissection. And now, importantly, we can look at a shape score that indicates how far along the shape mode each shape is. Large positive scores are associated with no dissection and large negative scores with dissection. This can be summarized in a box plot, and we see that the shape scores are statistically significantly different between the two groups. So in conclusion, dissection is a complex pathological event with a very high mortality rate. The current risk score of maximum diameter isn't sufficient at predicting dissection. We can see that two shapes with the same maximum diameter, one can dissect and one can't dissect. And this is because their shapes are very different, as indicated by their shape score. So risk scores, perhaps based on the full geometry rather than maximum aortic diameter, may provide better prediction of dissection. And better prediction allows us to administer better preventative care and for better patient survival. Thank you.
Thank you, Jessica, for highlighting your research on aortic shape. That was very interesting. Okay, everyone. We are going to, or you are going to provide some feedback to Jessica on her talk, and using the same link. I think Rowan, can you just maybe share that just in case someone has just joined us and they didn't receive it previously, and then once we'll give you a minute to provide feedback to Jessica, and then once we're done with that, we can give you the link to, or refresh the link to rank the winner. So I think just take a minute to provide some feedback, and then we will refresh that so that we can choose, or you can choose the winner.
I'm going to update it right now so you can now rank the
winner. Again, just a reminder to the audience to select the winner. Number 1 will be the winner, and then you can still rank them 1 to 4. And based on this ranking, we will choose the finalist.
All right, I just sent you a message, Josh. We've got a critical mass. We've hit the number of votes.
Okay. Okay, so we have a winner, and would like to congratulate Jessica Williams. Unfortunately, we don't have a live audience to hear the cheering, but congratulations, Jessica.
Thank you very much.
And I think someone from the BRI will be in touch with regards to your prize. And congratulations to the rest of you. You did a great job. I think we will also be providing you the feedback given by the audience so that you can take away some constructive feedback and for improvement of your next presentations. But thank you all. This has been a great session. And thank you again to the audience for voting and providing your feedback and being a part of this session. And I think the next session at Discover Brigham is at 12:30. And the session is going to be on what we know about COVID-19.